I'm happy to be here today to talk to you about what causes an aortic dissection. Now, you've already heard about a type A and type B aortic dissection. And for the type A dissections, there's typically an aneurysm or some enlargement of the aorta that occurs prior to the dissection. So what I'm going to talk to you about now is not just a risk for dissection, but also a risk for aneurysm formation, since it's a spectrum of disease. So here's the list of the major risk factors for aortic dissection. By far, the major risk factor is the forces on the aorta from the beating heart, and the major causes for increasing those forces is hypertension. So this really emphasizes how important controlling your hypertension is to prevent aneurysms and acute aortic dissections. In addition, we know that people can have alterations in their DNA that predispose to them, in other words, those genetic changes. And these two factors, the hypertension and the alterations in the DNA, are the major risk factors for aortic dissection. The others listed here are minor risk factors. A bicuspid aortic valve does increase your risk for an aneurysm, but our data currently say that these aneurysms rarely progress to dissection. Men are at an increased risk for dissections, more so than women, with about a ratio of 2 to 1. Pregnancy is a low risk for dissection in the general population, but if you've inherited one of these genetic alterations, then your risk with pregnancy will go up. And then finally, we have some data, not very good data, but some data that drugs and two classes of drugs increase the risk for dissections. Hypertensive drugs called calcium channel blockers may increase the risk for dissection, as do fluoroquinolines, a type of antibiotic. Until we have better data, we really would recommend that people limit the use of these drugs and not stay on them long term if they know they're at risk for an aneurysm or a dissection. So let's get back to the genetic alterations. So we've known for a long time that Marfan syndrome, that you can alter just one gene in the human genome, and that confers a high risk for dissection. We know people with Marfan syndrome have this inherited predisposition in a single gene called FBN1, and that predisposes them to dissection. More recently, we've learned about alterations in other genes that predispose to Loeys-Dietz syndrome. So these people have these syndromic features, so that helps us pick up these people from the general population and start managing their aortic disease. Now we know that there's a large number of people out there like John Ritter. John Ritter unfortunately died of an acute aortic dissection, and after his death, we got a history that his father, Tex Ritter, died suddenly, possibly due to an aortic dissection, and that Tex Ritter had relatives that had aneurysms, thoracic aortic aneurysms. So after John's death, we realized there was this family history. We went and imaged his brother. His brother had an aortic aneurysm that was repaired to prevent a dissection. And John's brother is alive to this day because we were able to pick up the fact that aortic aneurysms and dissections were running in John's family, despite the fact that he didn't have any syndromic features. We now know that up to 20% of patients with thoracic aortic disease will have a family history like John Ritter. So for both the syndromic causes, the Marfans, the Loeys-Dietz, and the families like John Ritter, in the vast majority of cases, it is inherited in the family in an autosomal dominant manner. Now, here's a pedigree. The squares are men, the women are circles. A line between a square and a circle indicates that they're married, and the line down is their children. When the symbol is filled in, it means the individual is affected. So in this family, with the father's affected and the mother's unaffected. So with autosomal dominant inheritance, this involves a gene, a single gene in the human genome. And for most of the genes in the genome, we have two copies, one of which we got from mom, one of which we've got from dad. In this case, the father has a normal gene and an altered gene. And the mother has two normal genes because she's not affected. Now, when they go to have their children, the father can pass on the normal or the altered gene, and it's a 50-50 chance whether he passes on the normal gene in black or passes on the altered gene shown in red. And this is classic for autosomal dominant inheritance. With somebody that's affected, has a 50-50 chance of passing it on to their children, whether the children are male or female. And once the children have that, they have a 50-50 chance of passing it on to the next generation. And as I said, 20% of patients will have a family history of thoracic aortic disease that mostly follows a pattern of autosomal dominant inheritance. And here's a huge family where there's multiple generations of people affected with aortic dissection. And the dissections can occur at variable ages, cause variable expression. This person dissected at 65, where his granddaughter dissected at 27. And it can also show decreased penetrance. So in this pedigree, this grandfather has the disease, passed it down to his granddaughter, but the daughter and the mother in between those two symbols is unaffected. So this is called decreased penetrance. In other words, the person has to have that altered gene, they pass it on to the children, but they themselves don't have disease. So my lab and other labs around the world have been working to identify the genes that predispose to these heritable thoracic aortic disease. This is the current list of genes that predispose to heritable thoracic aortic disease. And as you can see, the list is long. But despite having this long list of genes, we only can find the causative genes in about 35 to 40% of families. So we can solve or identify the causative gene in some of the families, but still the majority of families, we have yet to identify the causative gene. So now all these genes are on DNA diagnostic panels and are sequenced to identify those alterations that predispose people to to thoracic aortic disease. So genetic testing. Who needs to undergo genetic testing? Anybody with features of Marfan syndrome or Loeys-Dietz, anybody with that family history of thoracic aneurysms or dissections, and we're currently recommending anybody with an aortic dissection under the age of 60. Now, when we go to do the testing, we really need an affected individual in the family to test. Before you get testing, the diagnostic labs will let you know your out-of-cost expense. Most insurance companies are covering all the costs for genetic testing, or at least the majority of the cost. One note I want to make is that you cannot be discriminated. If you have a positive test, you can't be discriminated against for medical insurance, but you can for life and disability insurance. So you need, before you get testing, you really need to address your life and disability insurance. For this testing, we typically collect saliva. We just have people spit into a tube, and all those genes on that list are tested at the same time. And it takes 4 to 6 weeks to get back the results. Now, if your genetic testing is positive, this becomes very important and powerful information for you and your family. You can use that change to identify who's in the family is at risk for thoracic aortic disease and who is not at risk. You can use it for family planning and this has to be done before conception if you don't want to pass on the variant to the next generation. It helps once we have the exact alteration in the exact gene, it helps us determine the clinical management for you and your family. It'll tell us when to time the surgery. It can help us predict whether you're going to have a type A or a type B dissection. And it predicts what may happen to your other arteries. So some of the genes will predispose to intracranial aneurysms, whereas the majority do not. At the same time, there's other genes that will predispose to early onset coronary artery disease and strokes, whereas the vast majority of the genes don't. So we really want to move into this gene-based management so we can get ahead of all these problems with the arteries and hopefully prevent any dissection, aneurysm, or other vascular diseases. So myself and other investigators in the field have launched the Montalcino Aortic Consortium. This is a consortium to collect data on individuals that have mutations in a known gene, collect all the clinical data, put it into a database, and use that to learn more about how to correctly manage these genes. And I really urge you to participate in MAC. Here's the email to request to participate. And for MAC, we need individuals that have a genetic alteration in one of those known genes. And then finally, I want to talk about what if you have not had genetic testing or the testing is negative. And this is probably the most important part of this talk. If you have a family history of thoracic aortic disease and negative testing, you need genetic counseling to identify who in the family is at risk, and those individuals need to be imaged for an aortic aneurysm. We don't need the actual gene to prevent dissections in family members once we know that the risk for aneurysms and dissection is running in a family. We just need to do the imaging of everybody at risk. In addition, if you have negative testing or a variant of unknown significance, which is equivalent to a negative test, you need to image, and you're the only person in your family that is known to be affected, we need to image all the first-degree relatives for aneurysm. That means your parents, your siblings, and your children. And furthermore, the current treatment guidelines say that all patients who've had a dissection, that we need to go ahead and image all the first-degree relatives for aneurysm, whether or not there's a family history. So CT and MRA are fine for this imaging. Echocardiogram can be done if both the root and the ascending aorta can be fully visualized. And once again, if you have an aneurysm or dissection and an aneurysm is found in a family member, then you need genetic testing and genetic counseling if you haven't already had them. So I hope this helps you understand your risk and the risk to your family for thoracic aortic disease. And I just want to take a minute to acknowledge all the people in my lab and collaborators, and then the sources of funding. If you have a family history and the gene has not been identified, once again, contact the John Ritter Research Program so that you can participate in our research and help us get the answer for every single family out there. So thank you.